I'm Dr. Mikio Nihira. Prolapse has been bothering women since the beginning of time, as far as we know. But unfortunately, prolapse tends to be very confusing to patients and their families. The purpose of this video is to help educate people about basic information about prolapse. Now, I'm going to be showing some shocking pictures, so I want you to keep that in mind before we continue with this video. To get started, let's talk about normal anatomy before we start talking about prolapse and abnormal anatomy. So what we have here is a side view of a woman's internal anatomy. Here's her front, here's her right leg, and in this case we're looking through her left leg. We have her pubic bone in the front, and the tailbone is represented in the back. We have her bladder, her urethra, that's the tube that she pees out of, the vagina, the uterus at the top of the vagina, the cervix, which is at the bottom of the uterus and the opening of the uterus into the vagina, the rectum, and the anus. And this is going to be an important reference for the rest of our pictures. Here's our first picture of prolapse. On the left side of the screen we have our normal reference picture, and on the right you can see that the uterus is about halfway down in the vagina compared to the picture on the left side. It's important to understand that this patient being depicted with uterine prolapse may not have any sensations of uterine prolapse because nothing is coming outside the opening of the vagina, which is depicted here. The uterus is about halfway down, so that she may have prolapse, but she may not even be aware of it. In other words, she doesn't necessarily feel anything coming out of her vagina because her uterus, in this case, is tucked up and away. Here's a picture of more profound uterine prolapse on the lower right side of the screen. On the left, we have our normal picture of anatomy. On the right upper picture, we have the picture of the lady with prolapse of the uterus about halfway down in the vagina, and the lower right side, the uterus is coming all the way out of her vagina. The lady can generally feel that there is something coming out of her vagina with her fingers, although with this degree of prolapse, she generally won't see anything between her legs. It's important to understand that some ladies can have prolapse all the way down to their knees where they have something coming out of their vagina and they can actually see it protruding out between their legs. We have a picture of a rectocele on the right side of the screen. Now on the left we have normal again, and on the right we have the uterus about halfway down in the vagina, and you can see that there's a bulge of the rectum into the vagina. There's a larger bulge of rectum into the vagina on the picture in the lower right, where in this case it's bulging way out and coming out of the lady's vagina. With ladies with very large rectoceles like this, sometimes they have to decompress, or they have to push the stool back towards their anus, depicted down here, in order to initiate bowel movements. Now we have an example of an enterocele, or what is called vaginal vault prolapse. It's important to understand that women can have prolapse with or without the uterus present. So ladies who've had a hysterectomy do not have a uterus anymore, and this is what our picture is showing on the right side of the screen. So we have descent of the upper portion of the vagina, and you can also see a relative descent of the bladder outside the woman's body. Here is a picture describing more of what will be called a cystocele, where prolapse of the bladder is observed. In this picture, you can see that there is a large prolapse of the bladder compared to our reference picture on the left side of the screen. And you can also see a relative descent of the upper portion of the vagina down towards the opening compared to this picture. Now I'm going to show the shocking pictures of actual prolapse. Here is a picture of a lady with complete uterovaginal prolapse. This is her cervix that's coming out of the opening of her vagina, which is depicted here. This is a picture that's very similar to the picture we showed earlier of the lady with complete uterovaginal prolapse. This lady would actually be able to feel with her fingers her cervix coming out of the opening of her vagina, but she may not actually be able to see it coming out of her legs when it's coming out maybe 1 or 2 centimeters from the opening of the vagina. Here is another lady who can feel prolapse coming out of the opening of her vagina, probably to a greater extent than the lady that we just saw previously. This is a lady who doesn't have a uterus, but she has significant prolapse, in this case, of the anterior wall of the vagina, or the wall that's shared with her bladder. Her bladder, in other words, would be on the other side of this wall of her vagina. This is her urethra. This is the tube that she pees out of. We don't know how many women experience prolapse in the United States. It's been estimated that a woman's risk of having surgery for prolapse is about 1 in 8, or about 11%. There are about 400,000 surgeries each year in the United States, but we don't know how many women have prolapse in general. Earlier, I mentioned that there are many women who have some degree of prolapse who aren't even aware of it. There are no large epidemiological studies, and what that means is there's no large studies in which thousands upon thousands of women have actually been examined in a systematic way. And to make matters more interesting, there are multiple ways that physicians and nurses can measure prolapse. So what are treatments for prolapse? Prolapse has been bothering women for thousands of years. And for thousands of years, women have been wearing pessaries. These are examples of different styles of pessaries that can be inserted in the vagina. In the past, women depended upon clinicians to insert and remove these devices to keep them clean. But in most cases, women can take them in and out and clean them themselves. What surgeries are available for prolapse? And there are many surgical options available. We divide these into reconstructive approaches, in which we're trying to employ the woman's own connective tissue to reconstruct the support of her vagina. Compensatory approaches, in which, particularly in the case of women who have recurrent prolapse or prolapse that has come back after prior surgery for prolapse, in these cases, we tend to use plastic materials or permanent materials in order to re-support the vagina. And lastly, there are obliterative surgeries. These are surgeries in which the vagina is shortened considerably to reduce the sensation of prolapse by essentially bringing the walls of the vagina together to keep the prolapse from coming out of the body. Here's an example of a reconstructive approach. This is a picture attributed to Dr. Robert Schull, in which the uterus has been removed, and the upper portion of the vagina, here is the lower portion, this is the opening here, here's the bladder, and here's the rectum, and here's the vaginal walls. And the upper portion of the vagina are being attached to the uterosacral ligaments. These are ligaments that run on either side of the rectum using suture. When these sutures are tied down, this will support the upper portion of the vagina, and it'll reduce the apical portion of prolapse here. Generally, it also reduces other forms of prolapse, like prolapse of the bladder and the rectum into the vagina. Here's an example of a compensatory approach. This is a picture created by one of my mentors, Dr. Jeff Cundiff, and what's being depicted here is synthetic mesh has been sutured around the vagina, and this is being attached to the anterior longitudinal ligament of the sacrum, which is a ligament that runs in all of us by our tailbone. This is shown doing an open abdominal approach, which was popular in the 1990s. Today, I mostly approach this myself with regular laparoscopic instruments. This is an example of laparoscopic instruments in which small incisions are used to access the peritoneal cavity or the cavity of the abdomen. And then through these small incisions, we suture the mesh material around the vagina and attach that to the ligament that runs over the tailbone. Here's an example of an obliterative approach, and what we have is our picture of normal anatomy on the left side of the screen. I should point out that in normal women there isn't a big air opening of the vagina. Normally the vagina, actually the anterior wall here, these two walls touch each other. So in obliterative approaches, they're taking advantage of what normal reality is, but they suture these walls together to make the vagina very short, and that's what's being depicted on this picture on the right side of the screen. If you would like more information about prolapse and other kinds of urogynecologic problems can be found at our American Urogynecologic Society patient fact sheets. Thank you very much, and here's some contact information.